Okay, hello everyone, this is Dr. Pruett. Today we are going to be talking about diabetes and some of the associated emergencies with this. I think it's an important topic because it's incredibly prevalent in our community and in our state. Diabetes, as we know, is all about sugar, and sugar being in the wrong place and not being able to get to the right place to help the body do its job. So if you look at the national statistics, these are from the CDC in 2013, so it was several years ago, but you can see that the majority of the burden of diabetes is concentrated in the southeastern United States, but we do have a pretty bright red spot on our map here in New Mexico as well, just to the west, which absolutely affects Bernalillo County and most of our patient population. If you look at diabetes over the years, it's just increasing in prevalence throughout the entire population. It is a very expensive disease process that is associated with a lot of other chronic diseases and increases medical costs and complications in chronic diseases in our patient population. And more people are suffering from diabetes. If you look at the death rates in New Mexico, this is some statistics from the Department of Health. We're well above the national average in people that are dying from this disease. So it's absolutely important to know about and to understand because we're going to see it a lot in the field. So risk factors for diabetes, there's some things people can fix and there's some things people just can't fix. So the non-modifiable risk factors, that can be related to family and genetics. You can't fix your age, you can't change your race, and you really can't help your medical history to an extent. So you start with those cards, and then the things that you can change would be activity level, diet, exercise, weight, blood pressure, and cholesterol. And all of those factor into type 2 diabetes as well. Things that are associated with diabetes and are very common and chronic complications of this disease, the two big bad ones are strokes and heart attacks, but we know that peripheral artery disease is a consequence. I'm sure we've all seen or known people who have lost limbs due to diabetes and had to have limbs amputated because of poor blood flow. The vessels in the eye are specifically targeted with high glucose levels, and that can lead to problems with the retina or problems with the lens, which is cataracts, or problems with the pressures in the eye, which would be glaucoma. And then there's also, as we know pretty well, problems with the blood flow to the kidneys, which is what leads a lot of diabetics that are poorly controlled to end up on dialysis. So big picture takeaway here is that diabetes, even though it's ultimately a problem with sugar, it affects all of the major organs in the body and can have some major consequences for the heart, the brain, the kidneys, for sight, and for mobility. There's a syndrome that's associated with diabetes. It's referred to in the medical community as the metabolic syndrome. And that's your patients that you see on a regular basis that tell you that they have heart disease and high blood pressure and high cholesterol and type 2 diabetes. It's a pretty common triad that we see frequently in emergency medicine. Other things that are associated with this syndrome as well are dementia. They do have higher risk for cancer. Some of the females have higher risk for polycystic ovaries, which comes with a whole host of other problems. And then fatty liver as well. Metabolic syndrome is associated with increased risk of developing cardiovascular disease, stroke, kidney disease, peripheral arterial disease, cancer, and dementia. And it's pretty scary statistic when you think about all these risk factors that 1 in 4 U.S. adults has metabolic syndrome, and that's largely a consequence of our diet and our lack of exercise and our lifestyle. An interesting physical finding that you can look for on your patients, some of them will tell you that they have diabetes and some of them won't know it yet. But there's something called Acanthosis Nigricans, and that's just a fancy word for this dark, velvety skin that you tend to see in the, we call it the intertriginous areas, but the armpits, the neck, the groin. And that is a skin finding that you might see that strongly suggests that that patient has resistance to insulin, and if they don't have diabetes, they're pretty close to developing it. And you might encourage them to get checked. So if you remember, if we go back to our pathology and pathophysiology, cells require only 3 things to do their job, right? They need oxygen, they need sugar, And ultimately, they need those two things so they can make ATP to fuel the body so the cells can build the things that they need to build to keep the body going. So if you look at cellular metabolism, remember we've got oxygen that goes in, and that's carried by red blood cells, and that helps glucose move into the cell to make those 36 ATP molecules, and then everything works like it should. Well, insulin is a very important piece of getting that glucose into the cell so it can help make ATP. And if you look at the insulin molecule here, it has a specific binding site on cells where there's a receptor. And when insulin binds the receptor, it essentially opens a gate so that sugar can come into the cell and help make ATP. So if you think of insulin like a key that unlocks the cell so glucose can get in. Now in type 1 diabetes, the problem is that the pancreas is not making insulin, and so there's no key to unlock the cells to let the glucose in, so the glucose stays in the bloodstream and can't get into the cells. So functionally, you have cells that are starving, right? Even though there's a ton of glucose around, there's no way for it to get in, and that's what causes a problem. Type 1 diabetes tends to happen in younger children, whereas type 2 diabetes, over time, it's not so much a problem where the pancreas can't make the insulin. It's a fact that the sugars, there's so much sugar in the bloodstream, and so much insulin is constantly having to be released to manage all of this sugar that the body becomes resistant to the insulin, and insulin isn't as effective as moving glucose as it used to be, and that's called insulin resistance. And over time, as that insulin resistance progresses, cells become unresponsive to insulin altogether. So if you think about insulin deficiency, on one hand, it causes hyperglycemia, right? That's too much sugar in the blood, not in the cells where it needs to be. And too much sugar in the blood, the kidneys are going to do their best to filter that out, and so it causes a large amount of water loss, which leads to dehydration. On the other hand, as the body's trying to process all this extra sugar in the bloodstream, but the cells are functionally starving and they're not getting the glucose they need to make ATP, they have to go to their backup pathways to make energy, and that produces a lot of keto acids, which causes an acidosis, and acidosis can lead to life-threatening arrhythmias and hyperkalemia. So there's two big life-threatening problems that can be a consequence of insulin deficiency. And if you think about the symptoms of diabetes, they start to make sense, and it all comes back to osmosis. But patients that are developing diabetes are hungry, right? Their cells are telling their brain that they're starving, and so there's signals to the brain to eat, right? So diabetics are going to be very hungry all the time. And not only that, but we talked a little bit about these patients getting thirsty, and the reason for that is the high concentrations of sugar in the bloodstream cause an osmotic effect where more water is pulled into the bloodstream and less water is into the cells. And same kind of thing with hunger, is the cells are starving for nutrients, but they're also starving for water, and so they're telling the brain to drink more because the cells need more water, when really there's water in the bloodstream, it's just not getting where it needs to go. And then as this water is in the bloodstream, the kidneys are going to start to filter it out because the kidneys recognize that there's too much volume, and that's why patients developing diabetes tend to need to urinate all the time, because there's too much water in the bloodstream. As cells are starving and not able to do their job, patients will actually lose weight as fats and proteins start to break down, and as fats break down, that's going to increase the production of acids and ketones. And all of this functional starvation is going to lead to some pretty profound fatigue. So when you think about what's going on, all the symptoms of diabetes start to make sense. So if you have a body that's not able to functionally use glucose, and glucose is not getting into the cells where it needs to get, and it's stuck in the bloodstream, the backup pathway, which I've mentioned before, is to make ketones. And the way that that happens is in the liver. And the liver is sensing the extra sugar, but is also responsible for providing extra fuel for the body and for the cells to do its job. And the way that it does that is threefold. It starts to break down fatty acids as a secondary alternative to glucose metabolism, and it also starts to break down proteins. And those two things, as they break down, the body can break them down and use them for energy, but a byproduct of that is ketones. And that's how the body ends up in acidosis, because of the backup pathways. If the body isn't able to use sugar to make energy, it'll use fat and muscle, and as a consequence make too much acid. And that's what leads to diabetic ketoacidosis. So it's the breakdown of muscle cells, the breakdown of fat cells, and the body's inability to use sugar to keep everything going the way that it should. There's different kinds of ketones: acetoacetate, beta-hydroxybutyrate, and acetone. You'll see these as well in patients that are starving to death, like in Africa or somewhere where there's no access to food. It's basically the final common pathway of any patient that does not get enough carbohydrates and is breaking down their proteins and their fats. So for all of you on the ketone diet out there, that's why when you're towards the end of your diet, your breath starts to smell pretty funny, like nail polish remover, and your body fluids might start to smell that way too. It's because functionally your body's starving, it doesn't have enough carbohydrates, it's producing ketones, and one of the ketones that it's producing is acetone, and that's why breath starts to smell like nail polish remover on the keto diet. So diabetes is the number one cause of renal failure. The way that it does this, or one of the proposed mechanisms, is that it constricts the vascular supply to the glomerulus, which is where all the filtration happens in the kidney. The kidney's really good at keeping what's good and getting rid of what's bad, but the sugar starts to clog everything up, and it makes the basement membrane where that filtration happens, it makes it really thick and hard for the filtration to occur. And as that becomes thicker and thicker, there's deposits that build up, and then the kidneys become less and less adept at filtering the blood, and they functionally get clogged with sugar. As kidneys start to fail, the body can no longer regulate potassium levels, and so one of the life-threatening consequences we see in renal failure is hyperkalemia, and this is a fantastic hyperkalemia EKG we got from Rescue 8 a while back. If you look at it, you can see all the classic findings of hyperkalemia. There's peak T waves, I think most easy to see in V3, V4, V5, but also what you're starting to see is that there's a really wide QRS, and it's almost starting to become a sine wave. And not only that, but this patient is also starting to become bradycardic, and all of these are signs that there's impending cardiac arrest. This is absolutely a patient who needs calcium to stabilize the myocardium, but also albuterol to help move the potassium into the cells where it needs to be and out of the bloodstream where it's not dangerous anymore. Another consequence of diabetes is cardiovascular disease. Patients with diabetes are up to 4 times more likely than the general population to have a heart attack or a stroke. It's a very dangerous disease, and they're very high risk. So anytime you have a diabetic with chest pain, take that very seriously and realize that because of their diabetes, their nerves might not be as functional as people without diabetes, and so their perceptions of pain might be off as well. So don't just go based on how severe they tell you their pain is. If they have fatigue, or they're feeling nauseated or dizzy, or anything that could suggest cardiovascular disease, have a high degree of suspicion in your diabetics that there's something going on with their heart, because they are at such high risk. Especially elderly diabetic females. Be very wary with these ladies. They tend to have very vague symptoms when they're having very serious medical problems. So if you have, for instance, a weak and dizzy elderly lady, make sure you're getting 12 leads on these patients, because they can mask their heart attacks. They don't present with the classic chest pain that you're used to seeing. They can present with simply weakness or dizziness or some other fairly vague symptoms. Take them seriously, and remember to get a 12 lead. When we think about diabetics and their problems with their limbs and amputations, it's really a problem with microvascular disease, and it's the very tiny vessels in the body that are most affected by diabetes. So if you look up here on the left, this is a small artery in a foot, and this is what a normal artery would look like a couple cell layers thick of an arteriole, a little bit of muscle in there, and then a vessel. But if you look over here at a diabetic, there's all kinds of extracellular matrix deposition and clogging of that small vessel, so there's very limited room for blood flow to get through, and it essentially cuts off blood flow to the rest of that limb. And it's the same thing that happens in the kidney. Here you can see a small artery in the kidney, nice big room for blood flow, a couple cell layers thick of the vessel. But you look over here in the diabetic vessel, and as that deposition occurs in the matrix, the lumen of the vesicle gets smaller and there's less blood flow delivered for filtration, and that's what ultimately leads to kidney failure. Here's a little diagram of what actually happens is that proteins start to accumulate, then there's cholesterol deposits, and that causes inflammation, and that makes the diameter of these small vessels even smaller. Which makes sense when you think about the small vessels in the eye, right? So some of the consequences in vision for diabetics, or you can have problems with the retina where it's full of small vessels in the back part of the eye that get clogged by the same metrics that you see in the kidneys and in the periphery of the fingers and the toes and the feet. Glaucoma is a problem with pressure where there's a matrix actually in the canal that helps regulate fluid flow through the eye. And then cataracts are caused by a deposition inside the lens that make vision cloudy. We all know that diabetes can cause neuropathy. That's problems with nerve signaling in the feet. But like we talked about before with acute coronary syndrome, it doesn't just affect nerves in the feet. That's the ones that people notice the most, but it affects nerves everywhere. That's why people don't necessarily feel their heart attacks the same when they have diabetes. But with regards to the feet, it causes numbness, tingling, kinds of a pins and needles sensation. But over time, patients completely lose sensation altogether. I've seen diabetics that come in walking on fractured ankles because they don't have any pain sensation in their lower extremities. As the nerves become damaged by the high levels of blood sugar, the vessels, the small vessels that we talked about earlier that get clotted off with that matrix, the vessels can't feed the nerve anymore, and then the nerve sheath that conducts the electrical signaling starts to wear away, and then the nerve can't conduct signals anymore, and there's no more pain perception in the feet. Now, why this is a problem is because if we have pain for a reason, right? It's kind of a warning sign to stop doing what you're doing. And if you don't feel pain sensation normally, you're prone to fractures and infections and all kinds of other bad things. And so these are some pictures of diabetic foot ulcers that happen because of peripheral neuropathy and can lead to very bad infections in the bone, which we call osteomyelitis, or complete vascular occlusion, which is a major cause for a lot of our amputations. It's important to realize and to think about your diabetic patients as being immunocompromised, just as immunocompromised as your patients with HIV or your patients that are on chemotherapy. They don't have as good a production of proteins that signal the inflammatory cascade. Their lymphocytes and their neutrophils don't work like they should. And then the blood flow, if you think about it, it's blood that brings the healing to the body, right? The white blood cells have to travel through that vessel to get to the area that's injured. And if they can't get there, then there's going to be no way for the body to really start to heal itself. And so all those things together functionally make your diabetics immunocompromised. So not only, and you think about their feet, so not only are they not feeling when they're injured, but they're also not able to heal it, and it causes a whole lot of problems with infection. So if you have a hyperglycemic patient, there's 5 things basically that cause it. Number 1, I think of infection. You know they're immunocompromised. Always look at their feet. Consider UTIs. Consider pneumonia. They're at higher risk for pretty much every infection you can think of, and those 3 would probably be the most common. Ask them about fevers. Number 2, if anything is infarcting, so like heart attack or like a stroke, or even the kidneys, if the kidneys have suddenly lost blood flow as a consequence of their diabetes, blood sugars can skyrocket and become hard to control. Another cause for patients to have higher blood sugars than normal would be pregnancy, so make sure you're asking your females of childbearing age if they're pregnant. A lot of times with our hyperglycemics, the reason their sugar is too high is just because they're not using their insulin or they're not watching their diet. So those are the 5 things I think of when somebody's hyperglycemic, and I try to tailor my questions to those things to try to figure out why. Now, in terms of managing your hyperglycemic patient, just like always, we start with our ABCs. Nothing's different there. But realize we talked about why they're dehydrated early on when you think about their cells kind of starving and the fluid and water balance. So it's fair to give them IV fluid. Make sure you're considering a 12 lead, especially in your little old ladies with kind of nondescript and vague symptoms. They can absolutely hide their heart attacks. So make sure you're doing 12 leads and then transport. Remember the osmotic cause of their dehydration, and you're just, by giving them IV fluid, you're trying to get more fluid into those cells where it needs to go. So we've talked about hyperglycemia, now giving some consideration to low blood sugar. The symptoms that you'll typically see could be a patient who's shaky, who maybe has altered mental status, they're sweaty, they might get anxious at first. The brain is the organ that absolutely needs sugar the most, and if the brain's not getting enough sugar, it's going to start to manifest that based on mental status and behavior. So make sure you're checking the blood sugar on most patients. If you do have someone who's less than 60, I know you know this, but you can give oral glucose if they're still with it enough where they can tolerate swallowing something without aspirating. If you need to, you can start an IV and give D10. If you can't get an IV, there's the IO option. It is okay if you have started an IO on scene and your patient wakes up and wants to refuse. If you're in that circumstance and they don't want to go to the hospital, it is okay to remove that IO if you need to. But try to figure out why they're getting hypoglycemic. So the acronym that I remember regarding hypoglycemia, if you're not an acronym person, it's fine, but this is kind of the algorithm I go through in my head when I'm wondering why someone's blood sugar dropped. I think about their kidneys. They might be taking too much of their insulin, which is exogenous or coming from out of the body, so that's just a fancy way to say they're taking too much. It might be a problem with their pituitary gland, which regulates their hormones. Many of our liver failure patients don't have the ability to generate their own glucose from their liver, and so liver failure patients tend to get hypoglycemic, and that would go as well with our alcoholics because they tend to have problems with their liver. Sometimes certain cancers can cause it as well, or infections. So those are just things I think about when people's blood sugar is dropping without a really great explanation. One thing you need to think of is if you get called to a stroke patient, just make sure you're checking the blood sugar on them, because low blood sugar can absolutely mimic a stroke. It'd be slurred speech, altered mental status, maybe weakness, sometimes facial droop. It's a very well-known mimic of a stroke, and I know we're very good at checking blood sugars, but it's just worth mentioning here. The other time you absolutely want to check a blood sugar is anytime someone has a seizure. So low blood sugar can cause seizures as well, especially in children, so make sure you're checking a blood sugar. One thing about pediatrics, though, and checking blood sugars is you really only need to check a blood sugar in kids if it's clinically indicated. It hurts, right? Like, nobody wants to be stuck in the finger with a needle and made to bleed, especially if you're a little kid. So unless you have a kid who's altered or unresponsive or has had a seizure or has a history of diabetes, those are all absolutely indications to check. But don't feel like you have to check a blood sugar on every child. It's not going to help, and it's really just going to hurt them. One population where it's really important to think about blood sugar abnormalities would be our homeless and alcoholics. Remember that their liver just doesn't work that great, and they don't have sugar stores like the rest of us. So make sure you're checking a blood sugar on your alcoholics with altered mental status, because it can get low. Another interesting medical problem just to think about is your patients who are chronically exposed to steroids, whether they have some sort of cancer or maybe they have lung disease, maybe they're on steroids for an autoimmune disease. They can develop something called Cushing Syndrome, and they have a pretty typical body habitus that you see here. So they call it a moon facies, so big round face. Those abdominal striae, that's the marks that you see on the skin there, central obesity, and then small, thin extremities. And when you see that in a patient, or you know that they're on chronic steroids, realize that they have, because they're on chronic steroids, their adrenal glands are not going to be able to respond to a stressor, say like an infection, like they normally would. And the adrenal glands, when they're fighting an infection or they're responding to stress, they tend to release more sugar so that the body has more fuel to do what it needs to do to fight the stressor. But if the adrenal glands are suppressed, they're not going to be able to respond, and that can be another cause of low blood sugar. So if you have a patient who's hypoglycemic and you can't explain why, a good question to ask is if they're on chronic steroids. And that is all I have. If you have any questions, please ask the 7-8 or feel free to reach out to me.